So SIRT or selective internal radiotherapy has been around for almost 1.5 decades. It is not the same SIRT that we were doing 15 years ago. We have moved on. We have refined our technology, our way of identifying the best possible patients. But yes, it has been around for 15 to 20 years. So it is a very multi-dimensional procedure. Number of specialties are involved, and a lot of work goes on before actually treating the patient. There's a lot of background work looking at liaising with other professionals, looking at the scans, and as I said, identifying the most appropriate patients for this particular procedure. Once we have given the go-ahead that this particular patient is going to go for the SIRT, and once you've done the adequate consenting, then we start the ball into motion as to how we do the procedure. So typically, the procedure involves a couple of admissions, overnight admissions, a week apart, sometimes 2 weeks apart. In the first admission, the first overnight stay, the radiologist does angiogram for the hepatic vasculature and see as to what is the blood vessel anatomy like as far as the liver metastasis and as far as the liver is concerned. What does it look like? And then there are always some blood vessels which we don't want our radiotherapy to go to, and the radiologist takes the opportunity of cordoning them off, or as we call as embolizing them. But this initial procedure is just a look-see procedure. We don't actually do any intervention, and we let the patient go the next morning, and then over the next few days we study the images that we have obtained, and then make a final call as to yes, the patient is suitable or not suitable for the actual procedure. So like I said, typically a week or 2 weeks later, we recall the patient. Again, this is a typically overnight admission, sometimes 2 nights, depending upon how the patient fares. When I say we, I mean the interventional radiologist. He goes in and again goes into the liver vasculature, identifies the tumor supply, the blood vessels supplying the tumors, and then injects the radioactive beads into the liver arterial vasculature, and that is it. And then the procedure is done. We make sure that the patient is okay, not having any bleeding, bruising from a site of arterial puncture. We keep the patient in overnight, and once the patient is settled, we let the patient go home. And as far as technically concerned, that is the end of the procedure. Obviously, we do some scans as well, make sure the dye has gone in the right place. But otherwise, the patient is free to go home. So the most commonly used radioactive beads are the yttrium-90 resin beads. How do they look like? They are very tiny, smaller than the thickness of a hair, microscopic really, and we have millions of these resin beads, which are soaked in yttrium-90, and they are injected or infused into the patient. So they're very, very tiny. So the most commonly treated cancer with this particular treatment is colorectal cancer with liver metastasis, and that's where my expertise is in management of colorectal cancer. The other tumor types where it has got some usage, some evidence, is in hepatocellular carcinoma, for example, selected patients of cholangiocarcinoma. There are other rare tumor types as well that we sometimes use, but the evidence is weaker in those patients. We also use it from time to time in selected patients with breast cancer once other treatments have been exhausted. So again, to emphasize, we're talking about secondary liver cancer, colorectal metastasis. That is the niche that I operate in. As far as the treatment is concerned, we have to be honest with the patient. This is a palliative treatment. This is to try to control the liver disease for as long as you can. It is not curative. And although from time to time, patients do very well and go on for surgery, that will be regarded as exceptional and highly useful. But the norm is that this is a palliative treatment. In terms of survival, what we're hoping to do is for these patients with colorectal cancer, with liver disease, improve their life expectancy, improve the survival. Typically, we delay the progression in the liver by about 3 months, 4 months, and that is the sort of advantage that we get with these patients. The procedure has to be reserved for a small number of patients who have got liver metastasis from colorectal cancer and not widespread disease all over. So I would have actually studied the images in great detail even before I see the patients, because the importance is to select the patients, as we said, and if you select the right patient, then you get a better outcome. So, like we said, the procedure has been around for 15 years, and we learned a lot in these 15 years. Previously, we used to treat more number of patients. Now, I get more referrals, but we choose the patients that can be treated. So yeah, a lot of work goes on even before we see the patient. What is happening with the radiology? What is happening with the blood tests? Is the liver reserve okay? What is the other systemic treatment that the patient is having? Is the patient on chemotherapy? Is the patient on other drugs, for example, Avastin, which need to be stopped for a few weeks? So a lot of groundwork before the procedure. Once we have decided that yes, it is doable in principle, then I would invite the patient for a review, see the patient face to face, take the patient through the consenting process. We have to discuss the pros, but we also have to discuss the cons of the procedure as well. There are very important side effects that we need to go through. And once the patient has had further time to think about the procedure, then we typically call them maybe 2 or 3 weeks later. Like I said, the procedure is done in two different steps, two inpatient steps, and once the procedure is done, maybe typically about 10 to 12 weeks later, we would do a scan to see how the treatment has worked. More often than not, especially with colorectal patients, along with the SIRT, I would like them to have chemotherapy as well, because I know that they have a synergistic effect.